I'll try to give you an overview of diagnosis, management, and screening of NAFLD. Tomorrow, I will concentrate on NAFLD in HIV infection. Now, I will speak generally regarding the general population about this problem. Well, to begin with diagnosis, first of all, we have to know what is NAFLD. I'll start with the definition of the problem, and then the main aims to diagnose NAFLD, liver biopsy or non-invasive techniques. What is NAFLD? It's a fatty liver. A fatty liver is a liver in which there are equal or more than 5% of hepatocytes with fatty droplets. Then a fatty liver might be due to secondary causes, drug, alcohol, essentially alcohol, or inborn disorders. If you rule out all of these, then you may consider your patient has NAFLD, non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease can be divided itself into simple steatosis, non-alcoholic fatty liver, and NASH, non-alcoholic steatohepatitis, which is the important stage of NAFLD. Liver biopsy provides the essential items to diagnose NAFLD. First, steatosis. Without steatosis, there's no NAFLD. Then you have to look for ballooning, which is a sign of hepatocyte death, of hapatosis. And then you look for lobular inflammation. So that if a patient has in a liver biopsy steatosis, then you can consider NAFLD as a possibility. Then you look for ballooning. If there is no ballooning, your patient has simple steatosis. If there is ballooning, then you have to check for lobular inflammation. In the presence of lobular inflammation, you can diagnose a patient of NASH. So this is a histological, a liver biopsy-driven diagnosis. And NASH is important because of this. NASH can progress to advanced fibrosis and cirrhosis, and rarely it may also progress to liver cancer without a previous feature of cirrhosis. Probably about 40 to 60% of the patients may progress from simple steatosis to NASH over 3 to 4 years. Probably this is an overestimation. Probably patients need far more time to progress from simple steatosis to NASH. Anyway, patients that today have simple steatosis in the future may have NASH. Then, is any possibility of diagnosing NAFLD without liver biopsy? Well, we have a number of techniques, of imaging techniques that allow us to detect and even quantify steatosis: US, CT, MRI, and FibroScan with CAP. However, by no means we can diagnose ballooning or lobular inflammation. So NASH is a problem. Regarding FibroScan with CAP, CAP is an estimation of the attenuation of the ultrasound wave with the M-probe of a FibroScan device 502. The CAP uses the same data that you acquire when you're measuring liver stiffness, and you have both results at the same time. This was the first, this was the first study validating CAP against liver biopsy. They found nice diagnostic yield to detect and discard low stages of steatosis, less than 10% steatotic hepatocytes, or below 33%. It was less accurate to differentiate higher stages of steatosis. That's why a recent meta-analysis on individual data had tried to find improved cutoffs to diagnose different stages of steatosis. And these are the results. For detecting, for diagnosing patients as having a stage above 1, you may use this cutoff, 248 decibels per meter. The other two cutoffs are pretty similar to the originals ones developed by Sasso and co-workers. Then we also may diagnose and quantify steatosis using MRI. MRI-based proton density fat fraction, MRI-PDFF, is now commercially available in newer devices. It's an implementation of software over newer MRIs. The MRI can decompose the liver signal into its fat and water signal components and give you a fat fraction, a calculation of how dense is a liver, how much fat is in a liver. It gives you a range that goes from 0% to 50%, okay? So this, for example, is a study validating the fat fraction against, measured by MRI-PDFF, against liver steatosis in a biopsy, and you can see a very nice correlation between both. Finally, well, we can detect steatosis. We cannot diagnose NASH, but we can measure the consequences of NASH, fibrosis. Here is an example. This is a fibroscan. This is liver stiffness and fibrosis stage in a liver biopsy of patients with NAFLD. And you can see that advanced fibrosis and cirrhosis can be diagnosed using liver stiffness. However, there is a large overlap for earlier fibrosis stages, and probably you may misclassify patients using these other cutoffs. Finally, you can use some very, very simple and routinely available tests, blood tests, to rule out advanced fibrosis. So you can use FIB-4 or the NAFLD fibrosis score. The NAFLD fibrosis score is a bit more complicated than FIB-4 to calculate. But anyway, using the lower cutoff of FIB-4 or the lower cutoff of NAFLD fibrosis score, you can be very sure you're excluding patients that have advanced fibrosis. So you can say, okay, this patient does not have F3 or 4. In summary, you can detect steatosis using MRI, US, or fibroscan with CAP. You can quantify and measure the steatosis with CAP and very precisely with MRI. You can detect and measure fibrosis using MRI elastography. This is another implementation that is now commercially available. And fibroscan, of course, liver stiffness. You can use at the bedside, US and fibroscan. They are very convenient. US is low-cost method, technique, and fibroscan is intermediate cost. MRI is expensive. For follow-up purposes, probably the best is fibroscan because it's very easy to use. And all of them are limited by obesity, which is the main theme behind NAFLD. So that's another problem. Now we're moving on to management. To manage a patient with NAFLD, you need to know how severe is fatty liver disease. Then you have to identify the potential causes of it and treat them. So the good news is that the severity of NAFLD is directly related to the fibrosis stage, because fibrosis stage correlates with the risk of death. In this meta-analysis of 5 cohort studies with 1,500 patients, followed by 17 years, liver-related mortality exponentially increased with fibrosis stage, with greater rates of death for those with advanced fibrosis or cirrhosis. Okay, so you have to prioritize on those patients. What is the main cause in the general population of NAFLD? It is obesity. These are the most obese countries on earth, and the epidemic of NAFLD parallels these rates of obesity. Spain is not here, but we are catching up because in spite of our Mediterranean diet, we are getting involved in the international epidemic of fast food and sodas. So how do we get fat and fatter? People who become overweight just eat a little more calories than lean people. For example, 100 calories per day, that is half a tin of soda, means 4 kilograms of extra fat each year if you take the extra soda every day and you don't burn those extra calories walking for 13 minutes. Then overweight people exercise a little less. They walk less often, take the lift more often, walk more slowly, and play fewer games. So that's one problem. Second problem, if you drank only one serving of soda, of 1970 size of soda each day, the result is 4 kilograms of extra fat per year. However, today it's very, very easy to cross that border because the serving size of sodas have grown exponentially. In addition, the prices of sodas and other unhealthy foods are getting lower and lower, while healthy foods as fruits and fresh vegetables continues rising each year. So this is a problem that needs a double approach. On the one hand, you need community and a community, some political approach to this. You need regulations, including rationing, that means limitations on the size of portions, taxation, so that low prices are not an incentive for unhealthy food, limiting advertising, health warnings, etc. And then you have to go to your patient. Diet and exercise. Medication probably may aid in some cases, and surgery in very severe situations. Because weight loss is the treatment of NAFLD. If you lose 5% of your original weight, then you can reverse steatosis and decrease liver stiffness. If you decrease a further 7 to 10% of your initial weight, then you may decrease NASH. And if you decrease over 10% of your initial weight, you can see a resolution of NASH and fibrosis. So that's all. This is an example of a real patient. She weighed 91 kilos in 2012, and by 2017, she went down the threshold of 10% weight loss. Results: initial BMI, 31 kilos per square meter, CAP, 330 decibels per meter, which means severe steatosis. Over 66% of her liver was steatotic. But then decreasing her BMI to 26, that is not normal, it is not below 25, she reached this situation. CAP value, 210 decibels per meter, which is absence of steatosis. But people who lose weight are doomed to a failure, because the sooner you lose, the sooner you regain or even gain more weight than where you started up at the very beginning. So drugs are needed for all those that cannot achieve a weight loss. And many drugs are coming. All of these are phase 3, entering phase 3. Pioglitazone and vitamin E are those in the most advanced stages, but any of them has shown steatosis decrease, NASH resolution, and fibrosis decrease. So, finally, who do we screen and how? First, there's a warning. There's no cost-utility study on NAFLD screening. Okay, so probably we cannot make any statement on a general approach to screening, but we may give some individual recommendations. You should screen individuals at risk, mainly those with potential increased insulin resistance. Those are patients who are obese, who show the metabolic syndrome criteria, or very high-risk patients are type 2 diabetes mellitus patients. How? With what you have at hand, what is available at your units or at your centers. Usually it be US and liver function test. Ideally, it could be fibroscan with CAP. Probably MRI is not suitable unless you have a pre-selected patient for this technique. But probably the simplest, easiest way to screen for NAFLD is just use your home scale and recommend it to your patients. In summary, we can diagnose by non-invasive techniques steatosis and fibrosis. NASH is still a problem for non-invasive diagnosis. Management means weight loss, and weight loss can be accomplished by diet and exercise. Drugs are coming for those who fail to lose weight with diet and exercise. Screening, probably you may target screening at certain patients, but most probably you need to prevent weight gain in your patients. Thank you very much.